Presentation number 24 GIT for cases and discussion of the perianal fistula, prepared by Prof. Sharaf and revised by Prof. Hani Sami. The first case is this woman, 34-year-old, who underwent CT enterography. It presents a loop, localized loop, showing wall thickness, showing wall enhancement, and submucosal enhancement, and showing very luminal submucosal fat deposition and air and edema. This is Crohn's disease. Here in this case we have a young woman, middle-aged woman with a large mass, showing central scar, characteristic of fibronodular hyperplasia. These three are another case. Here the late arterial CT does not show the lesion well, but still the central scar can be seen inside. MRI was done, early arterial showing early enhancement of the region except for the central scar, but late both the scar and the mass are enhanced similarly. So the main point here is that the scar is not enhanced in early studies, whether CT or MRI, but late it becomes enhanced, and that the region in itself is hypervascular with contrast enhanced CT scans and MRI. It shows evidence of hypervascularity. So it tends to enhance homogeneously except for the central scar, which is usually late to be enhanced. Metastatic diseases usually are correlated with non-malignancy. Adenomas tends to enhance heterogeneously. Fibrolamellar carcinoma or hepatomas are behaving more vascular, more heterogeneous, more larger, and they presented no scars. And if the scar is following the same. Of course, fibrolamellar hepatomas tend to be correlated with the cirrhosis and hepatitis, which are the risk factors. So MRI is helpful in diagnosis of fibronodular hyperplasia, as it shows the central scar non-enhanced in early arterial. It shows the adenoma fat, and it can present early the characteristic malignant pattern, early enhancement, early washout in hepatomas, and metastatic deposits usually to be correlated for a non-malignancy. In this case, there is intersusception, small intestine into small intestine, and this intersusception is seen as hypo-intense in hypodense in CT, hypodense in CT due to fat, and this is the one. Loops with the mesentery and mesenteric fat are seen as hypodensity collapsed loops within the intersubsubient, and we have the chance to see this polyp as a head of for this intussusception, and this denotes hamartomatous mass, or what we call pedunculated polypoid mass, seen in Busch-Jaeger syndrome, which usually affects is an autosomal inherited and may be seen as spontaneous, may be associated with hamartomatous polyps and skin pigmentations, as the case here. The woman has pigmented lesions in the oral mucosa and lips. So the presence of pigmentation and the presence of polyp suggests the diagnosis of Busch-Jaeger syndrome. The other cause for intussusception is intussusception due to celiac disease, and here is the case. A 48-year-old man with history of sprue, axial non-contrast and contrast CT scan shows small bowel intussusception. This is the one inside here. This is the one inside here. Small bowel intussusception with a small bowel obstruction, that is dilatation. The transit intussusception is with coiled spring appearance, which was not associated with a mass. There is no mass. It's only loops within loops. The differential diagnosis is intussusception due to a mass. Is the associated celiac disease. So celiac disease is the other possibility. Those associated with a mass tend to be associated with small intestinal obstruction. Otherwise, going into the history, you may get any finding pointing to sprue. So we have two causes for intussusception: the presence of a mass, polypoid mass, hamartomatous mass, as in some of the syndromes, usually female, and number two, the history of celiac disease or sprue. Now, what it is? The liver is pushed with a large low density tissue which fills the peritoneum, and even the spleen is pushed aside and even extending into the pelvis. A 60-year-old woman with history of mucinous neoplasm of the appendix, multiloculated hypodense fluid collection in the abdomen resulting in scalloped liver and spleen. This is the spleen. Curvilinear calcifications in some. Multiloculated hypodense fluid collections in the pelvis, or low density, better to make it low density masses, because it may be gelatinous material and not fluids, not simple fluid. And this is the typical appearance of pseudomyxoma peritonei. Now here in this case, this is a 47-year-old patient with history of liver cysts on CT and underwent MRI. Now biliary hamartomas tend to be small. Biliary hamartomas tend to be small and scattered throughout the lung, throughout the liver. In Caroli, bile ducts are connected to the cysts because they are simple dilatations of the duct, and the cystic areas are communicating with the biliary tree. Multiple cysts, if simple multiple cysts, they tend to be less than 10 millimeter in diameter. Polycystic liver disease, of course, is characterized by being multiple homogeneous hypodense cystic lesions without wall enhancement, and maybe with hemorrhage and or calcification. Maybe with hemorrhage or calcification. So the differential diagnosis of here in this case, which is polycystic disease of the liver, is biliary hamartomas, Caroli's disease, and multiple sclerosis, and we have discussed it here. Carolia is cystic dilatation of the ducts. Simple cysts are small, usually less than 10 millimeter. Biliary hamartoma tend to be small and scattered throughout the liver. Here is the group of cysts that sometimes presenting focal bulges of some of them with soft tissues in between, thickened septa, maybe nodules. As a whole, there are soft tissue more than expected in hydatid. And there is no fever, and the patient is not giving any history of malignancy. So this is the typical appearance of biliary cystadenoma, which are generally intrahepatic. The key point is the presence of the soft tissue masses, either nodules or enhancing septa or thick walls. The differential is liver abscesses, cystic metastasis, and hydatid disease. Don't forget the bulging, focal bulges of some of the cysts. This characterizes biliary cystadenoma. Here in abscess, 28-year-old man with fever and right upper abdominal pain, right lobe cystic changes with thick wall reaching from 3 to 15 millimeter due to edema, and there is enhancing surrounding, enhancing capsule, and a peripheral rim of edema, as we said. Maybe it can extend outside the liver, like here starting to extend, and this is the typical appearance of amoebic liver abscess. Multiplicity, right liver lobe, thick walls 3 to 15, enhancing, maybe with internal septa inside, like this or that, and a peripheral rim of edema causing ill definition of the margin with possible extrahepatic extension. Calcification may occur. Now here we have something different. We have the large cyst with many peripherally arranged smaller cysts and showing calcification, or one of the germinal layer is separate, denoting water lily appearance, and here is total cyst at the periphery. So the multiplicity, total cyst, lily appearance, and total cyst may take care that total cyst is usually seen in 75% of cases. This all together point to hydatid disease. In biliary cystadenoma, we said that they are large, may calcify, but the main point is that the presence of soft tissue thickening inside, thick septa, neural nodules, focal bulge of the cysts. In hepatic abscesses, we have air and maybe the thick enhancing wall, as in this case, reaching from 3 to 15 millimeter thickness. And cystic metastatic deposit usually gives history of malignancy, while simple hepatic cysts usually show no enhancement. A 68-year-old man with abdominal pain undergoing CT showing multiple cysts, and these cysts are usually related to hemochromatosis The most important point is that although they show peripheral centripetal enhancement like that of hemangioma, but there is always a continuous capsule enhancement, continuous ring enhancement. This association of the continuous ring enhancement and the centripetal nodular enhancement, similar to that of hemangioma, are pointing to angiosarcoma or an atypical hemangioma or deposits. All may be simulating such an appearance, but what is first, so angiosarcoma multiplicity, ring enhancement, and nodular centripetal enhancement. Here we have this widespread small hepatic cyst, simple hepatic cyst with no enhancement, and of course hamartomas is a possibility, biliary hamartomas. Here we have this large mass with target appearance or central breaking down and markedly thickened enhancing margin that enhanced in early arterial phase, denoting malignancy, and more denser than malignancy in the portal phase. The appearance is that of metastatic deposits. Here we have deposits from pancreatic cancer, multiplicity, hypodensity, ill definition of the margin, contrast enhancement is limited, and usually areas of breaking down are seen. Lymphoma versus metastasis, since there is involvement of this liver and spleen as well as the kidney, so we should consider lymphoma as well as metastasis, either or. We have involvement of the spleen, liver, and kidney, as well as the presence of lymph nodes at the retroperitoneum. So lymphoma is more likely. Here is lymphoma of the liver, spleen, kidneys, and also the lungs, as well as the adrenal glands. Lymphoma deposition, infiltrations in all these organs: liver, spleen, kidneys, suprarenals, and lung. I'm just reminding you about the lymphoma of the kidney. It may be nodules inside, it may be nodules outside, it may be encasing the whole kidney, it may be just thickening of the capsule. All appearances can be there. So lymphoma may be intrarenal or extrarenal, in the perirenal fascia, in the filling the perirenal fascia. This one with nodular enhancing wall, so it is hemangioma. This one with extension and enhancing capsule, more with abscess. This one is bull's eye or target sign, more with deposits. And these are for differential diagnosis, likely deposits. Bronchogenic carcinoma with liver deposits and aortic aneurysm association. This is aortic aneurysm because usually you are dealing with an old patient. Aortic aneurysm, renal deposits, liver deposits, lung deposits. So bronchogenic carcinoma with liver, lung, and renal deposits. as well as aortic aneurysm with intramural hematoma. What about the technique for perianal fistula? We do axial and coronal T1. We do stair and T2 weighted images, axial and coronal. Images will assist for the topography, sepsis, anal sphincters, and pelvis or pelvic floor muscles. If this is the external sphincter, which is elevator ani, and this is the internal sphincter, which is confined to the rectum, and this is the dentate line between the rectum and the anal canal and the anus. And this is the elevator ani muscle. So we have this list of associations, either intersphincteric, that means that it is let us go to the next slide. It will show better. Intersphincteric fistula, seen as small protrusion around the anus, or it may be a larger collection, and here we call it intersphincteric with collection or intersphincteric abscess in the cleavage area between the elevator and the sphincter. Low down, you can say it is low. It's not affecting the elevator ani muscle itself. If it affects, it's called transsphincteric. A transsphincteric is a longitudinal one, more lengthy. It's not simple protrusion or not simple collection like this. This is protrusion and this is collection like this one. This is a collection. These three are the examples of intersphincteric with collection, and these two are the intersphincteric fistula protruding. And here is the lengthy one, which includes the elevator, and here is the lengthy one with collection, and the collection is outside here. Collection is outside here. This is the transsphincteric with collection. And then we have the extrasphincteric, away from the sphincter. The sphincter is anterior, and the lesion is sphincteric. It is aside, at the side of the sphincter, like here. This is extrasphincteric, inferior to the elevator ani. However, it may be involving from the parasphincteric region, but penetrating the elevator ani muscle. This one with collection, this one with collection. This is the region of the elevator ani muscle on both sides. It passed and penetrates into the above the elevator, and that's why we call it supra and infra elevator ani fistula. Supra and infra elevator ani fistula. This is grade 5. Then we are left with the horseshoe abscess, and in horseshoe abscess we'll find it crossing the middle line. Anything crossing the middle line is an example of horseshoe abscess. Thank you.